Straight from the Cutter's Mouth is now back with a Journal Club episode, joined by three retina specialists from around the country. We're going to work our way from east-south up to east-north. So starting with Dr. Nick Farber, who's in Tallahassee. Nick, welcome back.
Thanks for having me, Jay.
In the east-north, we have Dr. Yoshihiro Yonekawa in Philadelphia.
Thanks very much for having me back.
And I'm not going to be obnoxious and say it's the West Mid. In the Midwest in St. Louis, it's Dr. Sabin Dang.
Thanks for having me, Jay.
All right, let's do this. We got 4 articles to discuss. Big one, breaking news, hot off the press in the last couple weeks. It's actually 3 weeks out now. Time goes fast, but by the time this goes up, it's still within the last month. Is this Protocol W randomized clinical trial, the effect of intravitreal anti-vascular endothelial growth factor versus sham treatment for prevention of vision-threatening complications of diabetic retinopathy. This is an article by Maturi et al., published in JAMA Ophthalmology. And so, Yoshi, run us through this article. What was the design? What did they show? And then we can get into implications.
Yep. So this was another hot DRCR paper. The network is on a roll with Protocol V, Protocol AB, and now Protocol W. And the goal of this paper was to understand the role of anti-VEGF treatment in patients with non-proliferative PDR without DME. So they compared sham versus injections for patients with moderate or severe NPDR and no center involving DME. So this addresses a really interesting and, depending on how you view it, like an FDA approved, but sometimes controversial topic in actual practice. And so the study randomized 400 eyes, and patients were assigned to either aflibercept or sham. And the injections were administered 3 monthly back-to-back, and then 2 months later, and then every 4 months for 2 years. And from year 2 to 4, which is not part of this study, this particular paper is only up to 2 years, the injections were administered unless the eyes became mild NPDR. And of note, the eyes received rescue treatment of aflibercept injections if the eyes developed center involving DME with vision loss or high-risk PDR. And so about the results, here's the one-liner. Basically, anti-VEGF treatment resulted in less center involving DME, less PDR, and improvement in diabetic retinopathy severity scales. But there were no differences in visual outcomes. So the 2-year probability of developing PDR or DME was 16% with aflibercept treatment and 44% with sham, so about 3 times the risk reduction if you injected these patients. And the probability of developing PDR, similar, that was about double the risk reduction, developing center involving DME, about 3 to 4 times the risk reduction. But again, there was no change in visual acuity. And it's not that DME and PDR related issues are not visually significant, but remember that these eyes in the sham arm were rescued also. So it's not withholding treatment for 2 full years in the sham group. It was more delaying treatment and injecting if more standard indications arose. And so this was kind of similar to Protocol V in a sense, where they showed that delaying treatment of eyes with DME with good vision resulted in similar outcomes, whether you started treatment early or you waited until vision dropped a bit. I think the key here is that patients were monitored very closely, probably closer than how we normally follow NPDR. Another thing is that I think listeners are also probably wondering, and the main reason why I think most people don't treat NPDR routinely is the risk for endophthalmitis, and where you can get a 20/20 eye that can become NLP in a matter of days. And so there were 3 cases of endophthalmitis in the study, all in the aflibercept arm, and all were for prevention, not for rescue. And so we're still awaiting the 4-year readout of the study. So the final results are still pending, where some of these data could potentially diverge, where early treatment may result in better visual outcomes or may not. But for now, it doesn't seem to be the case.
That's a wonderful summary. There's a lot of stuff to talk about here. And I would kind of break it down into 3 big categories we'll go through. And I think the first big category is, does it work to prevent these complications? And the answer you answered, Yoshi, is yes. And we learned that in the Panorama trial as well. Just to run through limitations before we get into discussion, they mention one of the big limitations, which is also something to talk about, is almost a 20% dropout rate. So like that's always a concern with the diabetic retinopathy or eye disease study, is there is this dropout rate. We don't know what happens to those patients who disappeared. they talk about the limitations, again, aflibercept only. We don't have ranibizumab or bevacizumab assessed. So is it apples to apples if you're using a different agent? We don't know based on this trial, though you'd hope it'd be similar for PDR prevention. Not exactly the same design as Panorama. Panorama was actually, I think, more frequent in terms of the two groups, at least initially with the loading doses, than here, where it went pretty quickly to every 4 months. And that endophthalmitis rate is actually pretty atypically high. I mean, we know that there's an endophthalmitis injection rate. Most studies quote 1 in 2,500 to 5,000. I was going to say this study isn't even powered to pick up endophthalmitis cases. And we had 3. And unfortunately, they were all in the prevention group and not the rescue group, which is, I would say, is bad luck. But there is some evidence that maybe diabetic patients who get injections may have a higher rate of endophthalmitis than non-diabetic patients. That's been reported before. But Sabin, let's get into meat now. So if we talk about, first of all, the reduction, right? So if you compare the sham versus the treatment group, to me, one of the things that really stands out is even in the group that's treated, it's not a 0% risk. Like we always think anti-VEGF just works, and it does, and we take it for granted. And it's kind of a binary way to learn it, but it doesn't prevent everything. And maybe if you administered more often, it would prevent it. But this is actually not dissimilar from Panorama, where if you look at the treatment group, it's not a 0% risk of development of these complications.
I think you're bringing up a great point. I mean, at the end of the day, if we had a 100% guarantee we're going to prevent all pathology, then it's a much more compelling picture. But if I have a diabetic patient who is 20/20 in my chair and I say, well, this is the chances of us reducing your risk of developing these complications of diabetic retinopathy, it's a harder sell because it is not a 100% guarantee you're going to do that. And it is a little surprising to me at how much of these people still develop pathology on like anti-VEGF. So I think that is something for us to take home, that this is very aggressive disease in terms of their VEGF load, and it's just maybe quarterly and every 4-month Eylea is just not sufficient to suppress that.
I mean, the A1Cs, I always look at that. It was like 8.3, 8.6. This is actually way better than most of our patients we see in the clinic. So you would expect, and they're compliant. These are the patients who came back, not the 20% who disappeared. Nick, does this move the needle for you? Like talking about the results, Sabin's just referencing, I think Yoshi kind of implied that he felt the same, that this isn't necessarily something that's going to compel him to start treating these NPDR eyes. Do you feel similarly? And what's kind of driving your decision-making there?
I do feel similarly in that, we didn't see an improvement in vision. And at the end of the day, that's what we're talking to our patients about. They want to go home and read, and they want to see their families, and they want to be able to drive. I do think the fellow eye status in our real clinic matters a lot. If you've already had an eye that's lost to PDR, or you're getting injected for DME, we didn't see what these fellow eyes were doing. And so it could be that that person, when you're individualizing it, is more likely to develop a complication. I also, when they broke it down from moderate severe NPDR and severe NPDR, the severe NPDR, if we're getting kind of granular, progressed to PDR at 68% versus the moderate severe was 24%. So really getting granular, made a difference, made a big difference with PDR. And I know that this study wasn't powered to see those outcomes, but it certainly strikes a chord, as well as making sure that we are monitoring our patients every 4 months. That's what they did in this study. They had, very purposeful monitoring. And so I don't like to get my diabetic patients that much further than that. And it kind of underscores that diabetes is a chronic disease. When they show up in our clinic, we are seeing a path that they've been on for at least 5 years if it's type 2. And so we just, may have more information once we get to the long-term study to talk about visual outcomes and see some of these, convergence to PDR and clinical DME actually have visual outcomes.
Yeah, I mean, it'll be interesting to see what's the retention rate for 4 years with COVID-19. I mean, that's a fascinating thing to think about. And the retention rate for these studies, you look at Protocol S, the retention rate dropped significantly over time. So it's really a question, how much is that data adding if you're only looking at the patients who end up following up, and it's a small subset of the original. And Nick, you brought up a good point about the chronicity. I mean, this is the problem a little bit, I think, with maybe charts before, but now especially with EMR and carrying forward diagnosis, is patient comes in, we give them a static diagnosis. You're moderate NPDR, you're severe NPDR. And then it sort of gets carried forward, right? They're just that, but it's not. I mean, the study is showing it's dynamic. It's constantly changing. It can get worse, it can get better. And these patients change over months and years that we follow them. The 68% versus 24% is a great pickup. I think that I personally, and Yoshi, you can comment, I don't sit there and score between 47 and 53. I mean, very few of us are taking fundus photos and grading. We get wide field FA, which is not part of that standard DRSS grading. Maybe we'll get a new grading score based on wide field FA in the future. But I mean, it really makes me think. The other thing I think about is the patients who aren't treated, it's almost, again, like Panorama, almost 50% have some sort of issue / complication, center involving DME PDR in the near future. It goes back to Nick's point. I don't think you need to treat them up front, but you need to have a long conversation and kind of come to Jesus moment with them where you're like, especially if the first time you're seeing them, they're like, hey, we aren't doing this now, but there's a very, very high probability, almost a coin flip probability, that you may need me to do something in the future. And Yosh, I want to comment on one other thing. What do you, going back to the idea that not all these patients get completely better with anti-VEGF, that's a little depressing / sobering. I mean, I always think with Panorama, I thought the same thing. I think the interesting takeaway is maybe if you had an anti-VEGF treatment that was one time, people are looking at gene therapy, the port, something longer, maybe this would be worth it if the endophthalmitis rate was overall lower. If you're injecting once, let's say, versus multiple times sequentially, maybe this benefit is worth it, but it still underscores that's not going to solve all the problems if both in Panorama and the study, you have 15% of these patients still have some sort of issue while getting anti-VEGF.
Jay, I agree that the future, we will be treating more of these eyes with longer acting medications. If I were a patient with severe diabetic retinopathy, I would want anti-VEGF on board. Not every month, but if it's a one-time injection that lasts like a year, that would be pretty awesome. And I always mention anti-VEGF as an option when I see patients with severe NPDR, and the vast majority of patients don't go for it. I never push them, but I have a few patients who were really intrigued and wanted to do it. Their eyes look beautiful. And 3 to 4 times risk reduction, that's pretty significant. I know it's not a silver bullet, but a lot of patients do well on this. And I think that more data is great. I like the study for providing that information. And like you mentioned, it doesn't provide all the other physiologic factors like non-perfusion and stuff like that, that I think does matter. But I think that it's a good treatment option to have, and it's a direction that we're probably headed in.
Sabin, any other thoughts or comments on this study?
There's a couple of patients that I have on anti-VEGF for severe NPDR, and just like Yoshi said, these people look amazing. I mean, it really works to regress a retinopathy. But the issue I've run into is we get that initial success, but how do we keep that momentum going? How do we keep them interested in coming back? Because unfortunately, our patients' lives get busy, and this does not become a high priority for them. And what I worry is that we give them also a false sense of security as a retinopathy improves, and we say, oh, look, it's looking so much better. And they get this mental picture like this is no longer a concern for me. They don't really internalize the risk that they have by not coming back for their follow-up, because they're going to go right back to their old coin flip of a risk of getting PDR center involving DME. And I don't think that quite comes through, at least when I've used this on patients.
Nick, any final thoughts?
I just think we need to remember that this study, they started with fantastic vision. It was 20/25 or better. And that is not always the case in our own clinics, I must say, or at least in my clinic. Generalizing this to my general diabetic that I'm seeing, I think I need to take that into a factor as well. And I really think what we're looking for is disease-modifying drugs, which is a term used a lot in other areas of medicine. And I think we still have room to grow, especially when you see, like we were talking about, that disease is still progressing even when we treat it.
Well, let's continue on that theme, because the next article is called Topographical Response of Retinal Neovascularization to Aflibercept or Pan-Retinal Photocoagulation in Proliferative Diabetic Retinopathy. This is a post-hoc analysis of the CLARITY randomized trial. We did CLARITY actually probably a couple of years ago now. Nick, you want to tell us a little bit about this study? And it kind of ties into the point you just made.
Sure. So this was a UK-based study at 22 sites. And what they were looking for is, does the location of neovascularization, comparing the disc versus elsewhere, in PDR vary? And what does the effect of treatment modality have on this topographical regression based on whether they used aflibercept versus PRP? So this was a post-hoc analysis. It was done during the pandemic, but the actual trial was not done during the pandemic, just the analysis of a phase 2b randomized single-mass multi-center non-inferiority trial, the CLARITY trial. And so they included 120 treatment-naive patients with PDR. This was evaluated on color fundus photos and divided into 4 quadrants, and the patients received either intravitreal aflibercept 2 milligrams at baseline 4 weeks and 8 weeks, so in other words, monthly for 3 months, and then PRN 12 weeks onwards, or they got PRP, which in this trial was fractionalized sessions at every 2 weeks for the first 12 weeks. So it seemed like they were getting 6 treatments of PRP every 2 weeks, and then PRN. And the PRN came into play where treatment was defined as recurrence, persistence, or a new occurrence of neovascularization. So this included 75 men, 45 women, average age of 54.8, type 1 or type 2, 18 years or older. Interestingly, the treatment was switched to PRP if someone became pregnant or a blood clot developed during treatment. And the mean duration of diabetes in the trial was 25 years. That could be skewed by the type 1s. And the mean hemoglobin A1C was 8.8%. So the results. So at baseline, NVD with or without NVE was observed in 35% of PDR versus NVE only in 65%. So NVE was more common at baseline alone. And the NVE actually had a predilection for the nasal quadrant most commonly. Regression was higher of the NVE as well, 87.3% compared to NVD. Only about half of the NVD went away at 52 weeks, regardless of treatment. It was resistant to both of them. And at 52 weeks, the higher regression of NVE was seen with aflibercept than PRP, 96% versus 78%, but there was no statistical significance for NVD. As we talked about, NVE was most commonly first found nasal, then superior, then temporal, and then inferior at baseline. And the superior quadrant responded great with most regression and the least persistence or recurrence. And actually the temporal quadrant was the most resistant to regression. And there was also a lower recurrence in the aflibercept group at 52 weeks, which surprised me somewhat. So this brings to point a lot of ideas. Why is NVD so resistant? Treating this, oftentimes what we were talking about, we think we're treating, we're doing a good job. We're doing PRP or we're treating with injections. We think we should have regression of NV. I gave you the treatment, but we know from ETDRS that PRP causes a 50% reduction in severe vision loss at 2%, at 2 years. And I often remind patients, that's great. Who wouldn't take a 50% reduction in risk? But that still leaves out the other 50%, which is our coin flip. NVD, what this study didn't talk about and where the limitations are, it didn't talk about vision. Right. And so, does this disease translate into visual outcomes, vitreous hemorrhage, tractional retinal detachments? And also, we don't know long-term studies of, is this persistent NVD different than de novo naive NVD? Is it going to lead to the same visual outcomes? We don't know. And so they also didn't talk about any endophthalmitis rates or PRP side effects in this study. So that was hard to quantify. It was a post-hoc analysis, but that would be interesting to know. So what did everybody else think?
Yeah, I think you brought up the point I was thinking is it's a good study. I think it's cool. I think it's a cool study. And I think it's interesting to think about, like you said, the NVD structurally does not go away. The question that was not answered here is, does that NVD result in a worse clinical outcome, right? So is it actually still active in the sense that it is going to cause a complication, or is it quote unquote controlled? Now, we would assume we would like the NV, like you said, to go away completely, because if it makes us feel better if it's gone. But the question is those 50%, is that all 50% of those patients are going to do badly, or are they have NVD and it's structurally there, and it will always be structurally there? And if you went and did a vitrectomy for those eyes, we've all been in those cases, and you pulled on the nerve, you would get bleeding because those vessels are formed vessels, and those vessels are not going to shrink. They are there and they're adherent to the hyaloid, but maybe you are reducing vitreous hemorrhage or other complications by treating them with laser or anti-VEGF. The other issue with clarity we talked about last time we reviewed the full paper, the PRP is always a hard thing to assess in these studies, right? Because everyone does PRP a little different. Yoshihiro Yonekawa PRP versus Sabin Dang PRP versus Nick Farber PRP versus Jay Sridhar PRP. Hopefully it's similar, but it's not going to be exactly the same. Everyone does it differently. And they talk about, they did like fractionated sessions, which I think is necessary in some instances and there's warranted in some instances. But if you're doing that routinely, it is a little weak sauce. Pardon my true language for that. Like, I know that's not the technical term, but my point is, like, it's not surprising that you get better regression with anti-VEGF than fractionated divided sessions of PRP versus a quote unquote full session of PRP up front. And then you may get a more similar response in NV regression, but I don't know. But this again, this is a post-hoc analysis. They just had the data was available to them from Clarity. But Sabin, you had a point?
Yeah, no, I agree with you completely. I think with the PRP being fractionated, it's not really, I'm just having trouble taking this paper and applying it to my clinic, is I guess what I'm getting to is I'm not going to do fractionated PRP on my patients. I tried it, if I'm going to do laser, I'm just going to try to get them one and done because these patients may not show up the next time, and that's really troublesome. And then if I'm trying to do an apples to apples comparison of aflibercept with PRP, that's the comparison I would personally want to see.
Yoshi?
I agree. I also try to do one and done, indirect, laser photocoagulation, just blast away. And I know that's similar to Miami style also.
No, that's your ROP background. I like to sit down and do it at the slit lamp. But
oh, really? Okay.
My back hurts if I stay there too long. I'm soft.
You're a very tall guy also.
Yeah, well, I will say this. If I have to take, so when you said it won't change the way you treat your patients, it doesn't change anything for me either. But it does reinforce something to me surgically, which I referenced, which it doesn't matter how regressed a diabetic looks when you go to surgery. If you do choose to go to surgery for anything, vitreous hemorrhage, retraction, if you try to pull directly on the nerve, which many people do, depending on the case, they start there. I prefer not to do that unless it's necessary for the case. For this very reason, it almost always bleeds because there's almost always vessels there. Now, again, in many cases, you can segment around that and leave that, and it won't cause issues post-operatively. But again, I do think structurally those vessels are there, even if you gave them pre-op anti-VEGF, or even if you injected them for months like this study, or even if you did PRP, there is some neovascularization that's still there. And that's why I don't do this routinely, but I think Dan Jout dropped this as a bomb like a couple of years ago, and he was really pushing for like early vitrectomy. I think there's pros and cons to that, but I do think that we know that our current treatments within the office don't get rid of all neovascularization. Now, whether it's clinically relevant, like I was saying earlier, depends on the scenario. But I think, again, the only way to completely get rid of some NV is to inject and laser it and go in and lift it and physically cut it and cauterize it in some instances. And you want to be cauterizing the nerve. And so sometimes you just aren't going to get rid of every single bleeder, every single vessel. That's not the point. Nick was talking about vision earlier. The point would be, does the patient actually see well or maintain their vision over time? But Nick, any other thoughts on this paper?
I did find it interesting that the aflibercept group had less recurrence. I tend to, formerly thought of PRP as that's the more permanent treatment that's going to get in there and cause a sustained decrease in VEGF levels. That's not what this paper showed, regardless of their method of PRP. I'm usually a 2-session PRPer, just to throw that out there, but split it in half. I find patients have been tolerating that a little bit better for me. I don't do a retrobulbar block usually either for them. So maybe if I blocked them more. The other thing I was thinking, and I think this is just an avenue for future research, is what is going on at the disc? Why is it different? What factors are coming up from the posterior circulation, from the glial cells around there? Why is the disc NV different than the peripheral NV? And so I'm sure one of your smart listeners is going to figure that out.
Well, I'll bring it to Yoshi because he does peds. I mean, is it just a hyaloid issue, Yoshi? Does it just have to do with the insertion at the disc is different than at other places?
I think it's NVD speaks as it's a marker of more severe disease, and then you have more ischemia peripherally, and the local elevated VEGF will induce NVE more easily, I think. And by the time you have neovascularization of the disc, that's a really hot eye. That's why the majority of patients with NVD will also have NVE. And I think in this study, it was the minority that had NVD only. Plus, my one criticism of the study is that not every patient had ultra wide field angiography in this study, and only about half did, I think. And so if they looked at all the patients, that number may have been skewed even more, where there were no patients with only NVD.
Yeah, I think that your point is well taken about severity. And I think the other point is that to Nick's point about recurrence, I think there's been a couple studies that have shown the best choice for this patient is both PRP and anti-VEGF for that very reason. PRP alone does not achieve the same outcomes as PRP and anti-VEGF. We always think of PRP as more permanent, but there is something to the anti-VEGF effect that is different and complementary depending on the situation. So let's transition to the next paper, and I'll run through this. This is our last diabetic paper of the day. It's racial, ethnic, and insurance-based disparities upon initiation of anti-VEGF therapy for diabetic macular edema in the United States. This is by Malhotra et al. With Rishi Singh as the senior author, published in Ophthalmology just this past month. And this is interesting. It's a retrospective cross-sectional study. They used the IRIS registry and looked over a 9-year period starting from 2012 to 2020. And this is a significant number. I mean, IRIS studies are always great. And we've talked multiple times about the pros and cons of IRIS database studies. They're like the king of database studies in our field. 200,000 patient, injection treatments that were given for DME. So they looked at essentially what was available with insurance, Medicare versus private insurance, Medicaid. They looked at racial demographics that were reported in the chart. And I think the big take homes are unfortunately not surprising and match some other studies, is that if you have Medicaid, you tend to have worse insurance than Medicare and private, worse vision than if you had Medicare and private insurance. If you're non-Hispanic or white, you tend to have better vision than Black and Hispanic patients. And Black and Hispanic patients tend to have worse severity of diabetic retinopathy, as documented for these patients who are receiving injections. So it's interesting because I do think the IRIS registry has limitations, and we've talked about limitations of big data. It's messy. You're adding up to a lot of things. You're limited by what's in the chart. It's retrospective. But this sort of trend has been shown in multiple other avenues in terms of socioeconomic and ethnic differences in how care is received and insurance status and how it impacts this. So I think it's actually a very useful paper. And I think that it's something that brings to mind, what can we do as a field to address this? These are systems issues, right? Like this is beyond just the patient in your chair. It's them, but it's also all the things that are at home that you're not seeing, and their lives and how they differ. And some of this could be education between different cultures. Some of this could be just access, and maybe there's a strong overlap in terms of access when you compare socioeconomic groups and ethnic groups. So, Yoshi, thoughts on this paper? Did you like it? And what does it mean for your practice? Does it change anything in how you view things?
Yeah, I think this was a very important paper, and it supports the very well-known ophthalmic healthcare disparities. And you've done great studies looking at this question also. And as you mentioned, it is partly about the patient in your chair with the A1C levels, and that wasn't part of the study that I think hopefully it could be included in future ones. But also the socioeconomic demographic disparities that are dependent and independent of the medical issues. And you also have so many other things that play, like systemic racism and poor access to care, even nutrition and healthcare literacy. Everything is connected. And so there's a lot more work to be done.
You referenced A1C, and they talked about, I mean, one of the limitations, like you said, IRIS, you don't get all the data. And I think A1C is one of those things we like to record it, but I don't think it's uniformly recorded in everyone's chart. It's not like there's a section in your intake that asks for A1C. Maybe there is, but it's often left blank because sometimes it's skewed because the patients who do the worst don't know their A1Cs. They don't even know what it is, and you have to educate them on it. Sabin, any thoughts? You're practicing in St. Louis, which is obviously similar to Philadelphia and Miami, has its racial diversities and differences in kind of access to care.
I think this paper really is, as Yoshi and the rest of everyone's saying, is incredibly important because it does highlight the disparities that exist in ophthalmology. And this is something we see in any minority populations or lower socioeconomic populations. So this really, we all have the anecdotal experience that these patients are coming in worse than a Medicaid patient. If I have a Medicaid diabetic retinopathy referral on my schedule, I'm assuming that's going to be somebody I'm likely to do an intervention on. And this big data analysis really validates that anecdotal experience. And I think this is actually one of the huge strengths of IRIS. And I'm hoping to see more work in this area because, as we're pointing out, there is missing clinical data, but I think it helps us with a big picture in terms of if we want to advocate for our patients on a policy level, I mean, something like this is huge. You know, we've got such a huge number of patients, and we can actually go and say, look, geographically, these are the problems these patients are experiencing. This is what they're coming in with, this degree of blurred vision. Imagine what that's doing for their ability to work. You know, they're going to be higher unemployment rates. There's going to be higher, need for ancillary services. So this is something we can just help our patients kind of advocate for and getting them the resources they need so they don't even get to that stage.
Yeah, and Nick, Yoshi, and the guys at Wills have written papers that have focused on zip code. I think zip code has been useful as a surrogate for socioeconomic status sometimes, or distance. They use the distance from a zip code to your office, for example. That's another surrogate for access. Any final thoughts or points on this paper regarding the access issue? Because I'm sure you have patients, even in your own practice, it's an access issue in terms of how they can get into the clinic or even get to a primary care doctor.
I completely agree, and that is an issue in my clinic. 42% of these patients are where you and I practice. They're in the South, and so we obviously have the lion's share of this, or quite a lot. Access is an issue, but I think this paper underscores that everything that happens before they come into our clinic is an issue, and that's where the disparities lay. And then once they're in our chair, delivering that treatment on time and trying to get as much vision as we can. We all, subscribe to the fact that the better the starting vision, the better the final vision. And we can see that the disparities are occurring, that, if you are of a different race, if you are of a different ethnicity, you're starting from a lower starting point. And a lot of times that has to do with what happens before you get into our clinic. I agree, this is a really important paper for policy to go and show how can we educate? Where are we educating? What are the actual important strategies? And also something that's been brought up a lot recently is representation. And for ophthalmology, that's being proactive instead of reactive. We can take this data and say, why is, people are more likely to follow treatment plans, to see themselves as part of a treatment if they are represented, if they have a good connection, if they are, feel trustworthy with their medical, with their doctors and their medical team. And so where is our representation in ophthalmology, and how are we increasing the medical literacy in our region going forward?
So let's move on to our last paper. It was really well said, Nick. And Sabin's going to take us home. We're going to switch to AMD. And this paper is intravitreal aflibercept injection versus sham as prophylaxis against conversion to exudative AMD in high-risk guys. This is a randomized controlled trial. This is a fascinating study, actually. This is like a who's who of ophthalmology. We got Jeff Heyer and Nadia Waheed and Wyckoff and Brown and Shaw and Prenner and Dang. And Dang's going to tell us a little bit about this study.
Yeah, so thank you. This is, I thought, a really fascinating study design. So this is a prospective randomized multi-center trial looking at high-risk non-exudative AMD patients and giving them prophylactic aflibercept quarterly, so every 12 weeks over the course of 2 years, and seeing if we can reduce the rates of neovascular conversion in those patients. So it's important to know what the authors defined as high risk. So that's when a eye has at least 10 medium drusen, 1 large drusen, retinal pigmentary changes, and the fellow eye has been diagnosed with exudative AMD. So these patients were enrolled to either getting aflibercept or sham injections, again, quarterly for over 24 months. And the endpoint really was, at the end of the day, how many people converted to wet AMD at the by the 24-month visit. There was a total of 127 patients that were reported and resulted into the study. That's 63 and 64 in each arm, respectively. So cutting right to the chase, did this work? And this is actually a null result study where it did not work. 9.5% of patients in the aflibercept arm converted to exudative AMD by 24 months, compared to the 10.9% in the sham group, which was completely insignificant at a p-value of 0.98. Now, despite this study having a primary outcome that was a null result, I think there was a lot of really interesting questions that were generated through the sub-analyses and just the primary thing. To get to the first thing is, why didn't this work? You would think that if exudative AMD was a VEGF mediated process, the process of going to non-exudative to exudative was VEGF mediated, this should have prevented something, but it really doesn't look like it didn't do anything. So we can kind of discuss a little bit about that. I'd love to hear your guys' thoughts on that. And the other sub-analyses is, this study looked at people whose exudative AMD eye had converted 2 years before, less than 2 years ago, or more than 2 years ago. And there's this really interesting result that I think a lot of us have seen in our own practice, that if an eye has converted to exudative AMD over 2 years ago and the fellow eye hasn't, the probability of that fellow eye converting is actually much less. And it's almost a twofold higher rate of exudative conversion in people who have had a more recent conversion. And the last thing, although it was a small sample size, this study did use OCT angiography to find non-exudative CNVs, and non-exudative CNVs, again, being choroidal neovascular membranes without leakage or hemorrhage on exam or regular OCT. And this provided us a small sample size of actually randomizing people with non-exudative CNVs to getting aflibercept or sham injections. And what's interesting is that also made no difference. Those people with non-exudative CNVs still converted to AMD, exudative AMD, despite getting the aflibercept. So I think a lot of this generated a lot more questions for me than answers.
I think this is such a good study because, for the reasons you said, it's clean, it was well designed, and the null result is fascinating because it's not what you would expect. You would expect the opposite. And anytime a study gives you what you don't expect, I think it's really interesting to talk about. So there's a few things to unpack here. I mean, I think the first thing to talk about, let's go back to why it didn't work. We'll come back to that at the end. The power calculation was done. And so the first thing I always look when there's a null result is like, was the study powered sufficiently? And they defined their power calculation. I believe their statisticians said 128 patients what they needed to enroll. It seems like a small number, but the power calculation was there. Yoshi, this is kind of, again, I don't want to get depressing about it, but it's kind of like the diabetic talk. Anti-VEGF doesn't treat everything, right? Like we were talking recently, I was seeing a conversation with a retina specialist, patients who have submacular hemorrhage despite getting anti-VEGF therapy. Patients, there are non-responders to anti-VEGF therapy. That's been reported in studies, 5 to 15%, depending on the study you believe, in terms of persistent or worsening subretinal fluid, regardless, or intraretinal fluid, regardless of anti-VEGF therapy. And then the final question is, even if the study showed a positive result, what would be the number needed to treat for you to treat these patients, given what we have now, which is therapy, let's say every 4 to 12 weeks. So let's work backwards. So like, what would the result have to be for Yoshihiro Yonekawa to treat a high-risk patient? What would that risk reduction have to be for you?
No, I think we have to, well, first of all, I was really hoping that the study would work, and I was thinking that it would. Clement Chan did a similar study in his group previously, which was also a negative study, but it trended towards significance. And so I had my fingers crossed, but it didn't happen. I think that if you did do the injections every month on these patients, it would have worked. But again, that's a lot of patients who may potentially be harmed by the injections. And so for me, Jay, I'm not sure, but I think one thing we have to get really good at or better at is identifying the patients who will convert and catching them before that happens. And perhaps not prophylactically treating them forever, but catching them maybe a few months before and starting treatment early. And whether that's accomplished by not by humans, but artificial intelligence or other imaging modalities, I think that would probably be the way to go in the future.
Yeah, in this podcast, we focus on shallow learning, but deep learning probably would have been helpful to define treatment patterns here. And Yoshi, you referenced the quarterly treatment. Nick, going back to Sabin's question, let's go back. Why didn't this work? Is it because the injections weren't frequent enough? Do you think that if they had done monthly, as Yoshi suggested, that maybe they would have seen a difference?
That's an excellent question. Or is there just some other factor that is contributing to when that exudation actually breaks through? Is the development of the membrane one factor, and actually the exudation another, and that the breakthrough is just from some other cause? Treating these more often, as we said, it's going to incur more risk. We're going to have more endophthalmitis. We're going to have more patient visits. We're going to have more injections. And so you really would have to have a significant decrease in the rate of conversion. They also did their power calculations based on the ARED study, which showed a 35% conversion rate in a fellow eye of a treated eye. And so, perhaps that was an overestimation, or that, so maybe that number was off. Maybe a slightly different powered study, more patients would have shown a difference. So treating more often is going to be interesting when we also look at the port delivery system, because that's a constant amount. Are we going to start putting those in fellow eyes, in high risk eyes? I don't think
I'm
so,
shaking
but,
my head. Yeah. I mean, well, let's take
not with this data.
We got the port, we got longer acting therapies. It goes back to what we talked. What if we have treatment that is subretinal gene therapy? What if we have treatment that's intravitreal gene therapy? Are we going to treat fellow eyes? And then we got to talk about a separate thing, which we'll leave off the table today, is does that predispose to more dry AMD progression and geographic atrophy? And people talk about CMVMs being protective. We're not even going to open that because that's not what this paper was about. But the power thing is a good, again, that I go back to the power thing. And I think your point about the treatment, I'm just trying to think like, Phil Rosenfeld has identified a lot of these CNVMs on OCTA that don't have any subretinal or intraretinal fluid. And they find there is a certain percentage of them that eventually exude, but it's such a low percentage. He still recommends just watching until it happens and just monitoring them. And your question about the breakthrough is interesting too, because we know that AMD CMVMs are probably the best defined CMVMs we have in our field, because that's where the highest N of patients and the longest history of treatment and the biggest need for treatment. But those are the CMVMs that are the least likely to come off of treatment. Those are the CMVMs that are the most likely to need frequent treatment, as opposed to other types of CMVMs, myopic CMVMs, post-inflammatory CMVMs, traumatic CMVMs that can be dormant for long stretches of time and then can exude and can be dormant for long stretches of time, but are more likely to go through long periods where they don't need any treatment. And I wonder if it goes back to some difference, like you said, in the RPE and what's going on at that level. Maybe the breakthrough has nothing to do with the VEGF-mediated process, which is the CMVM formation, but something to do with the integrity of the RPE, which is already a problem in these patients who have AMD. Regardless of CMVM or not, they have an underlying RPE issue. Sabin, I don't know if you have thoughts on that or anything else people have said.
No, I agree. And the short answer is I don't have the answer. After this result came out, I spent a lot of time scratching my head because, it really made me question, do I understand exudative AMD? Do I understand what causes people to turn into wet AMD? And now I'm not so sure I do understand it.
Yoshi understands. Yoshi can tell us.
Please,
Yoshi, tell us.
The only thing I understand is that, this paper provided a lot of food for thought, and it's a question that we will continue to pursue, I think. And so, Sabin, on your next paper, I want you to figure it out, man.
There you go.
I thought you were going to say something really poetic, like the only thing I understand is I don't understand anything. But but that would obviously not be true. My last point before we break on this paper is, Nick, you referenced downstream effects, right? So like, are we going to be treating high risk eyes? Like, I think this paper reduces the chance that's going to happen, actually. Until we get evidence that, until we get evidence that treating high risk eyes is beneficial, are we going to treat the fellow eye of these patients with long duration anti-VEGF therapy? My answer right now, based on this evidence and what I'm feeling, is no. So I was shaking head at the port question. I would rather just see what happens, even though it's scary for a lot of these patients, although it could be individualized. Anyone feel differently? Do you guys feel kind of the same?
For the record, I agree. I do not want to put a port in a fellow eye. That was a pure speculation. But I do feel more comfortable getting out of that 2-year window like we were talking about, that hopefully that fellow eye can remain more stable.
And I think let's say hypothetically, this was a 10% conversion rate after 2 years. Let's say we had something that was 100% effective and we had 0% conversion, but we only helped 10% of that patient population. What does that look like from a healthcare economic standpoint? Do we take every high risk AMD patient and put them through expensive therapy to save 10%? I mean, for those 10% of patients, that would really be a big difference.
But it would be interesting cost calculation, because what is the cost of 10% of all AMD patients in this category going blind?
Yeah.
Like, I don't know the answer to that. I think the cost would probably work out in your favor because blindness carries such a big, devastating, psychological, obviously, but even if you were just a dollars and tax guy, I mean, it's economically, it's disastrous, right? So
right.
You're right. But I would say logistically, how would you do that? Like it'd be impossible. Like it would depend on your delivery method, but It's really a fascinating question. And then the real question is going to be, which we don't answer to, and I'm going to leave this hanging. We don't have to answer it today because we don't know the answer, is what happens when you do long duration anti-VEGF therapy and all of a sudden now their geographic atrophy is going out of control and you don't have treatment for that. And did you make that worse, or is that just the natural progress of this disease? Like Nick said, the 2-year window, I would imagine a lot of those patients don't fall in that 2-year window. It'd be interesting what percentage of those patients went down the GA pathway instead. Because maybe that eye is just behaving a little differently. And then if you do believe there's some correlation between CNVM formation and lack of GA, maybe that eye never formed a CNVM and therefore is more prone to GA. And I'm not smart enough to the answer to that. Maybe Yoshi or Nick or Sabin is, but any final thoughts from anyone before we break?
No, I think early detection is really important. When you're treating somebody's right eye with wet AMD coming in very frequently, their left eye, even if it converts, you catch it early, even if they didn't notice any symptoms, as opposed to the dry AMD patients that we follow every 6 months. On that 6-month visit, a lot of them come in with, rip-roaring CNVM, but they're like, I didn't really notice anything. And so prophylaxis is one, but early detection is another. And so home monitoring, et cetera, I think will be big in the future.
And that's just, again, the preaching of the choir. But I think we get so, I can tell my fellows and residents all the time, we get so caught up when a patient's getting injected in one eye, they're getting OCT, they're getting OCT, they're getting OCT. We're always looking at the treatment eye. You have to look at that study eye image, whether it's simply for liability reasons. I mean, the fellow eye, you have, but it's really for ethical reasons. You have to look at that eye because sometimes that's their better seeing eye. And you're right, Yoshi, a lot of times they don't notice the exudation. And that is the one side benefit of bringing them in for such frequent injections. They get the side benefit. Usually most practices will just quickly capture images of both eyes. Always review all those cuts, always look through them, because you're amazed how many times patients asymptomatic and you look and you're like, whoop, there's a new fluid there. And you may start treating them even if they're asymptomatic and they have good vision because the other eye does not have great useful and workable vision. So good. We ended on a positive note. I love it. You guys were great. Thank you so much for doing this journal club. Nick Farber, Sabin Dang, and Yoshi Yonekawa. Thanks again.
Thanks, Jay.
Thank you.